We're going to switch gears from radiology to molecular testing. It's a pleasure to welcome Dr. Lewis White from Public Health Wales, who's going to be talking to us about molecular diagnosis of invasive fungal disease. Dr. White, stage is yours.
Hello there. Can you hear me?
Yes, we can.
And can you see my slides?
Absolutely.
I'm going to keep my camera off for now, just in case we have some bandwidth issues. I am at home, so apologies in advance. I do have a dog and I do have a 4-year-old. So hopefully we don't get disturbed as we go through. Thank you, Lewis. As we said, I'm going to talk to you now about the molecular diagnosis of invasive fungal disease. There are my disclosures. Happy to chat about those if you feel the need to do so. So, like any diagnostic test, molecular tests, primarily PCR tests, have benefits and limitations. Are they the perfect test when it comes to invasive fungal disease? By no means, but I certainly think they can add something to the diagnosis of invasive fungal disease. One of their main benefits is that they provide us with a rapid diagnosis, certainly rapid in comparison to culture, probably comparable to the sort of antigen testing and beta-glucan testing in terms of turnaround time, probably nowhere near as quick as something like a lateral flow assay. However, they can provide us with a broad detection range. They can be truly pan-fungal should we design an assay to be that way. And no other diagnostic test really provides us with that level of detection. They can be highly sensitive, which is a good thing, but also a bad thing in that you can generate false positive results. But they can also be highly specific in a way that I've mentioned. They can have a broad detection range, but conversely, we can develop an assay that can pick up a sort of individual strain of a species if we choose to do so. They also have the capacity to pick up mutations that can be associated with antifungal resistance, and I'll touch on that in a few slides' time. And subsequently, they can be multiplexed to pick up a range of different genera, or looking at different species, or even species with antifungal resistance. Limitations come down to that you need specialist equipment and specialist staff. And it can be associated with considerable expense, particularly in comparisons of sort of more conventional testing, such as culture and microscopy. We do generate false positives, but the rates of false positive results are no greater or no less than what we see with galactomannan and beta-glucan. However, they do differ. They tend to be associated with sort of DNA coming in from sort of enzymes that are derived from fungi, but used in molecular testing. But you can also have contamination of blood-based vacutainers that can lead to false positive results. One of the major reasons for not using molecular tests is lack of standardization. However, that's not necessarily the case anymore, certainly for things like Aspergillus PCR through the efforts of the Fungal PCR Initiative, formerly known as the European Aspergillus PCR Initiative. We have standardized the approach for Aspergillus PCR testing, primarily of whole blood, plasma, and serum, but we're just about to report on standardization of BAL fluid as well. What we found was that amplification, Aspergillus PCR amplification methods and performance of these methods were comparable, and actually DNA extraction, nucleic acid extraction, was the rate limiting step, and that's what required standardization. And once you've done so, you can pretty much not guarantee, but the performance of your assays are generally going to be on par and consistent between centers. In terms of analytical specificity, we know that most assays, Aspergillus PCR assays, do target or are optimized for Aspergillus fumigatus, and the detection of other non-Aspergillus fumigatus species is less in terms of analytical sensitivity. And so the detection range does tend to focus on Aspergillus fumigatus, but really performance is obviously better if you have a wider range of sort of detection that you're picking up the Aspergillus genus rather than specific species. Commercial PCR assays are available. Many of these are CE marked. Most of them, I can't really think of any that are currently FDA approved, which is a problem for sort of gaining access to Aspergillus PCR in the US. But we do have external quality control assessment schemes, EQA schemes, which puts us on par with most other molecular diagnostic tests. And nowadays, when I first started doing Aspergillus PCR, we were extracting from whole blood, but nowadays we target serum or plasma, which actually means you can take a serum or plasma sample, put it onto a DNA extraction system, an automated DNA extraction system, and then perform PCR in line with what you would do for CMV PCR, EBV PCR. So really these assays are now suitable for incorporation into routine molecular diagnostic laboratories. And if you have access to a routine molecular diagnostic laboratory, there's no reason why they can't be actually performing Aspergillus PCR. In terms of performance, it's important to understand what you'd want from your test. Neil has already sort of gone into some details of pre-test probability and post-test probability, or both negative and positive. And when we're testing blood, you're actually looking at a high-frequency screening test. And what you want is a high sensitivity and a high negative predictive value to exclude disease. If you look at meta-analyses for galactomannan, beta-glucan, and Aspergillus PCR, when testing serum, you actually found that the sensitivity of Aspergillus PCR is greater than that of both beta-glucan and galactomannan for the diagnosis of invasive aspergillosis. And then subsequently, the negative likelihood ratio associated with Aspergillus PCR is getting to around that value of about 0.1, which is sufficient to exclude disease when Aspergillus PCR is consistently negative. Recently, the Cochrane review into Aspergillus PCR has been updated when testing whole blood or serum. And basically what we found is that single positive threshold maintains sensitivity and specificity around the 80% mark, again comparable to galactomannan for the diagnosis of Aspergillus when testing blood-based specimens. But more so, when you required 2 positive samples, the specificity increased significantly to 95%. If you look at the performance of Aspergillus PCR and BAL fluid, again, has a high specificity around that 95% mark. And so subsequently, if you look at the positive likelihood ratio, which needs to be greater than 10 to be deemed significant, you can see it's 12. And so it's basically these results, when you have 2 positive Aspergillus PCRs in blood or an Aspergillus PCR on BAL fluid, it's good for confirming disease. And this was really a requirement for the OR-TC-MSG consensus definitions, and so justifies the inclusion of Aspergillus PCR in such consensus definitions. We know that the impact of antifungal therapy, it's sort of deleterious to the performance of galactomannan, beta-glucan, and indeed lateral flow assays, where it reduces sensitivity. As part of this Cochrane review, we actually found that the antifungal therapy actually reduces the specificity of Aspergillus PCR, irrespective of whether we use 2 or 1, the requirement for 2 or a single positive sample. And basically, we hypothesized that this was due to the fact that we were looking at increased DNAemia through the action of the antifungal on the sort of the cell wall of the fungi. But more so, it was probably sort of the lesser classification of invasive aspergillosis due to the reduction in the sensitivity of the galactomannan analyzer, which was used as the reference test to define invasive aspergillosis according to the OR-TC-MSG definitions. And also you're in a situation that you potentially have less disease progression in this situation where you've got less hyphal invasion, and particularly Aspergillus PCR could then be picking up sort of organism within the respiratory tract. Nevertheless, what I think, and this is going to be an ongoing story through the sort of the diagnosis, the molecular diagnosis of fungal disease, is that a combined diagnostic performance, when we combine galactomannan and Aspergillus PCR, is optimal in blood. This is a study from Cardiff where we had a prospective cohort of 5 years from 2005 to 2010, and that if you basically required PCR or galactomannan to be positive, you had a sensitivity of 98%. The subsequent negative predictive value was nigh on 100%, and the negative likelihood ratio was well below 0.1. So if your tests were consistently negative, you could exclude invasive aspergillosis. Conversely, if both tests were positive on multiple occasions, you see a specificity of 95%. Positive predictive value, not as convincing, just slightly more than a flip of a coin. But in this situation, pre-test probability, as Neil alluded to, was only 9.7%. So we've actually gone from 9.7 to 57%. So that's quite a marked increase in post-test probability of disease when your patient has multiple positives. Positive likelihood ratio, when less likely influenced by incidence is greater than 10. So when you have multiple positive, you can see by multiple positive by both tests, you can see that there's a really good indication that your patient has aspergillosis. The best threshold is if you have a single positive by galactomannan and Aspergillus PCR, as highlighted by the highest diagnostic odds ratio. The combined performance of Aspergillus PCR with galactomannan has been confirmed by various randomized controlled trials from Europe and Australasia, and by meta-analyses that confirm that this is the way to go for the diagnosis of invasive aspergillosis in your hematology patient. In the non-neutropenia patient, well, the jury is still out. And probably what it does indicate is that we need to use a sort of a targeted specimen. And so subsequently, if we look at sort of the performance of Aspergillus PCR and galactomannan when looking at BAL, you can see the specificity of Aspergillus PCR is slightly better than that of the galactomannan ELISA. And in this situation, we have a BAL taken, we have a bronchoscopy performed because we're trying to confirm disease in symptomatic patients. So we need a high specificity and a high positive predictive value. And if you look at the positive likelihood ratio, as I mentioned, greater than 10, high confidence that your patient has aspergillosis when the patient is Aspergillus PCR positive in a BAL. And I think you'll notice on here, there's no BCD-glucan. On the previous slide, there was BCD-glucan, and that indicates that, in my opinion, BCD-glucan doesn't really have a role when testing respiratory tract specimens due to the presence of commensal organisms such as Candida and due to the presence of colonizers, which can generate quite a poor specificity and positive predictive value associated with BCD-glucan testing of respiratory tract specimens. One thing that has come to light recently is galactomannan BAL false positivity. In patients, this was work that was put forward by Connie Lass-Fleurl and Michaela Lackner from Vienna. And they actually found a significant association between galactomannan BAL false positivity and the presence of Candida, particularly a high burden of Candida greater than 10 to the 4 colony forming units per mil within the respiratory tract, and also increased GM false positivity within the presence of Candida glabrata. Nevertheless, specificity with a threshold of 1.2 was still around the 90% mark. One solution that we actually use widely in Cardiff is combining the galactomannan testing with Aspergillus PCR. We know that our Aspergillus PCR does not cross-react with Candida. So subsequently, when we have that combined galactomannan and Aspergillus PCR positive on a BAL fluid, we then convince that the patient has a really good indication of invasive aspergillosis. We're also in the situation here that molecular tests can pick up Aspergillus resistant strains. We know it's an ongoing problem, increased rates of azole resistance driven by the environmental mutations, TR34 and TR46. Historically, when we've picked up these CYP51 mutations, they've mainly been through Sanger sequencing, and then when applied directly to specimens, has been tissue or BAL samples. However, now we've got these real-time assays that can be applied to both BAL and serum, and actually do have some clinical utility. And a study in the Netherlands and Belgium now, they're actually showing that these have sort of influenced patient management and driven down mortality that can be high when associated with azole-resistant disease. They've also been used to actually identify other species within the Fumigati complex that have raised MICs to azoles, and this has been done through melt curve analysis. However, we do know genetic mechanisms for azole resistance are expanding beyond the TR34 and the TR46, and so subsequently pyrosequencing and next-gen sequencing has been applied to both sort of provide us with this sort of enhanced range of detection. But subsequently, we then have the issue of turnaround time and utility. If you're generating these results a week after the specimen, what is the clinical utility of such a result? And of course, in most of these patients, these were culture negative samples. And how do these resistance markers actually relate to MIC values? And basically, when we find these mutations, it doesn't always equate to an MIC that is associated with azole resistance. Moving on to PCP PCR and meta-analyses, what you can actually find really high sensitivity. And so subsequently, when PCP PCR is negative, you can pretty much exclude disease. And one of the problems with PCP PCR that's been put forward is basically the picking up of colonization or basically clinically irrelevant pneumocystis. But the specificity of PCP PCR is high, greater than 90%. And the positive predictive value and positive likelihood ratio are actually quite good and really sufficient to confirm disease when actually the sample is positive by PCP PCR. Of course, we also have real-time qPCR that gives us a quantitative result. And so this actually helps us interpret the sort of the significance of a positive PCR result. And the higher that burden, the higher the specificity. What about the HIV negative patient? Well, some recent sort of meta-analyses and systematic review by the Fungal PCR Initiative has shown that qPCR doesn't actually, the performance of qPCR doesn't really vary between the HIV positive or the HIV negative. And while the testing of upper respiratory tract specimens does lower the sensitivity to around 80%, specificity remains high at around 95% plus. Again, we have commercial assays that can pick up resistance markers associated with resistance to septrin and dapsone. However, the clinical utility of such tests is still to be proven on wide-scale studies. Standardization is underway, and it is included in the ORTC MSG definitions for the diagnosis of PCP. But going back to that combination testing, I would recommend that we combine qPCR testing primarily on BAL, but if not, you actually use a serum beta-D-glucan test and combine that then with qPCR on upper respiratory tract specimens. And in doing so, it allows us to both confirm and exclude the diagnosis of PCP without the need for deep respiratory tract specimens. I knew Neil would do a fantastic job basically discussing the diagnosis of invasive candidal disease. As he mentioned, we're trying to pick up this missing 50%. If you look at the meta-analysis of Candida PCR for picking up sort of candidemia, you can find that it's got really high sensitivity and really high specificity. However, this data is almost, well, it is actually 10 years old, and it's really, really important that we actually update this data with a new meta-analysis of Candida PCR. And we don't still know what the best combination of tests is to achieve an optimal diagnosis of invasive candidal disease. But there is a study going on in the UK currently that has been hindered by the COVID-19 pandemic that might provide us with a little bit of data on that. Standardization, we don't really know what the optimal sample type is. Is it whole blood? Is it plasma or serum? I know some work that Neil and Hong Wen did in Pittsburgh indicated that plasma and serum might be the way to go. But we are now having commercial assays, and there is external quality assessment schemes available for Candida PCR. What about resistance? Well, I think we might be able to develop direct resistance tests for mutations to the echinocandins, as these are primarily on FKS1 to FKS3 genes. However, for azole resistance, due to the broad array of sort of mechanisms associated with resistance, I really don't think it's possible that we're going to have sort of a real-time sort of qPCR test to pick up these mutations. And we are going to be reliant on sort of sequencing or next-gen sequencing, which does limit the utility of such testing. However, there are commercial assays and other assays available that pick up resistant species such as Candida auris, but also Candida glabrata and Candida krusei. When it comes to sort of the commercial assays, most of them have limited validation. However, the T2 Candida assay doesn't have extensive sort of clinical validation, and meta-analyses confirm that it does have a high sensitivity and a high specificity. And there is some nice sort of evidence now that it can be used as a prognostic marker. Some of the information from sort of the Madrid study indicated that the presence of a T2 positive was an early indication of the patient going on to develop invasive candidal disease, but also was an indication of mortality in your patient. And so some work from Papas's group has also shown that it can be an indication where there's a requirement. Positivity by the 2T assay can be an indication to increase the duration of antifungal therapy in your patient. And again, the T2 Candida PCR is included in the ORTC MSG definitions. In relation to the Mucorales PCR, we've got sort of BAL, sero and tissue PCRs described, picking up sort of the 5 main genera associated with Mucorales infection. We do have commercial assays available that are CE marked, but not FDA approved. And we do have standardization through the Fungal PCR Initiative that does actually show that the performance of these sort of assays is very, very robust between laboratories. Clinical validation is emerging, particularly from France, where there's a multi-center trial going on, looking at serum Mucorales PCR that's generated a good sensitivity, but also a very good specificity between sort of the 85 to 90% mark, and has shown some clinical utility. But again, this is work in progress. Finally, just looking at some pan-fungal PCRs, again, can be applied to blood, serum, or tissue, or sterile fluids. I've put BAL fluid here in question with a question mark alongside it because of the presence of commensals or colonizers. If you apply pan-fungal PCR to such a specimen, you're going to get a positive result, but what actually does it mean? And that also goes into the situation of sort of a pan-fungal PCR where it gives you a yes, no answer. Yes, fungi is present, no, fungi is absent. And I think the problem with those type of assays is that the sensitivity is compromised by such a broad detection range, and the specificity and subsequent positive predictive value is poor because of the potential of picking up these commensals, but also the situation that you can get false positivity due to sort of contamination with sort of environmental fungi during the extraction process required to perform Aspergillus or to perform PCR or fungal PCR testing. And so really we need to be sort of providing a genus or species level of identification, whether that's through probes or melt curve analysis, but more so sort of more evidence is available for PCR sequencing. And I think the problem with Sanger sequencing is a poor turnaround time and consequently limited utility of such a test. But it does, where it is useful is where you have sort of positive histology in a tissue specimen, and you can use PCR sequencing and pan-fungal PCR directly to that tissue specimen to try and provide you with an etiological identification. And there's also some work coming out of California where carriers have looked at a non-sort of a next-gen sequencing approach, looking at sort of DNA EMIA for fungi within plasma. And there's some sort of evidence coming out that this may be a useful approach. But I think really for pan-fungal, we're probably going to have to combine this sort of fungi yes, no as a frontline screen, and then providing some sort of etiological identification, whether that's through probes or through sequencing, to tell us what the actual fungi is. Finally, novel developments where we've looked at droplet digital PCR. We've gotten some evidence now for Aspergillus and Candida detection, and droplet digital PCR is where basically the PCR is split into tens of thousands of individual reactions. It provides us with a better degree of quantification and a more accurate quantification in relation to the fungal burden, and is also less prone to inhibition. We've also seen sort of the availability, or not from a commercial perspective, but from an R&D perspective, of proximity ligation assays, where they combine the use of sort of antibody testing or serological testing, so the specificity of serological testing, and they combine that with then PCR to enhance the sensitivity. And those assays hopefully should be becoming more available in the next few years. And of course, we've got next generation sequencing that can be applied to the organism, where we've actually seen sort of evolutionary studies. Certainly, we've just published a paper linking azole resistant Aspergillus in the environment to clinical cases across the UK and Ireland. And of course, there are epidemiological approaches where it can be used to investigate outbreaks, and also picking up resistance markers, whether they're known existing resistant markers or identifying new markers of resistance across fungal species. I mentioned the carrier system, where next-gen sequencing and pipelines are being used for diagnostics. And of course, we're using next-gen sequencing to look at the microbiome and the microbiome. And another application is where we actually apply it to the host to look for genetic markers that predispose the patient to invasive fungal disease. One of the problems we have at the moment with NGS is that the entire process needs standardization. Starting with extraction, where we need to optimize the extraction process. If we were trying to apply whole genome sequencing, unfortunately, fungi generally require very robust sort of mechanical disruption, which can also fragment the DNA, which then makes whole genome sequencing a bit of a problem. But also comes down to PCR amplification when we do apply to diagnostics or sort of microbiome work, where we use the ITS1 and the ITS2 markers or regions for sort of barcoding. They can give us different results when you compare the performance and the sort of the sequences that are generated by looking at those two different regions. And of course, the bioinformatics need to be optimized, as does the interpretation in relation to the patient's underlying condition, the specimen of choice, and also the biases that have been introduced by the molecular process itself. So that's just an overview of fungal PCR. I'm not going to dwell on that now. I'm just going to hopefully leave some time for some questions. My email's at the bottom. Please do email any questions that I can't address now as we go forward.
Thank you so much, Lewis, for that.
No problem.
Very, very amazing talk. We have a few questions on the chat. We're going to start with Dr. Nucci, who's asking if the effect of antifungal therapy on PCR performance is common to all drugs or limited to azoles.
Yeah, that's a good question. And in our study, it was primarily aimed at azoles because it was a prophylactic use of antifungals. And so you're not really going to see much use of amphotericin as a prophylactic drug, and you're certainly not going to see much use of the echinocandins as a prophylactic drug. So most of this was driven by the use of azoles.
Very good. And we have a question from Dr. Chandrasekhar. PCR colonization versus dead pathogen versus actual infection. How do you differentiate?
Well, this is depending on the organism. You're going to combine it with different things. And so generally what we've always said, let's look at Aspergillus. I completely agree with you. It could be colonization. We've got evidence to suggest through some work with Nathan, who's talking after me, that we've got PCR positivity in the animal model 4 hours after exposure to Aspergillus. That's not disease. That's just basically the patient. That's just the animal inhaling Aspergillus. And so what I would recommend is, one, it's the burden. How strong is the PCR signal? That can be an indication of disease, but more so combining them with antigen testing. And in doing so, we build up that confidence, particularly with galactomannan that's only released from actively growing hyphae. So from my experience, is that combining it with other biomarkers.
And along those lines, is there any role for quantitative PCR for differentiating colonization versus true infection?
Certainly in respiratory specimens, I think we can do it. But it brings in another slight issue in that we have to be happy with the quality of the sample. Not all BALs are the same. Sometimes you get a BAL which is primarily just saline. So you have to be sure that you've got a good BAL. But yeah, certainly quantitative PCR on BAL fluids works really, really well and should be applied. I think in blood, the problem we have is that it's the positives we get are right at the limit of quantitative PCR detection. And so they're either positive or the negative.
Great. We have a question from Dr. Chaturvedi in New York, who's very impressed with the data you presented regarding the standardization of the PCR. Are there studies where the same regions were used in multi-center trials?
So with a lot of this sort of the standardization, we were using spiked specimens. And so there is information there. There is some centers will be using the same regions, 28S and sort of the 18S. However, when it comes to the clinical evaluation, we've actually got data from 2 clinical trials, the ORTC trial that's just finished, and also the Ambigard trial, where we've got access to the data where the PCR using a single approach has been applied to multiple patients from multiple centers. And it does look consistent. However, that data is not currently available in the public domain, but hopefully sometime this year.
Very good. From Dr. Samadar, leaving aside the high cost, how is the performance of targeted NGS compared to the conventional PCR for diagnosis of IFIs?
I think we're in a situation that the jury is still out. At this moment in time, Carius data is probably the closest we've got in terms of sort of NGS performance director specimens, and it's hit and miss. We've got anecdotal data of case reports, some screening of neutropenic patients who've had fungal disease, and it's probably giving us, I think there's about 4 cases of fungal disease, and I think 50% of them were hit, were positive. And so we're in that situation that we don't really know.
Very good. From Dr. Zhang, in the absence of PCR, is there any value of comparing companion serum galactomannan to BAL galactomannan to adjudicate false positives BAL galactomannan?
I think that's a valid point, and I think in certain patient populations that will work. Your hematology patients, your neutropenic patients, you've got a higher likelihood of your serum galactomannan being positive. Your problem is going to be two things. I'm not convinced the hematology patients, certainly in Europe, is as neutropenic as they used to be due to the use of RIC MUDs. You know, in the past, the myeloablative approach for the allogeneic stem cell transplantation used to knock out all the neutrophils. Nowadays, they're not as neutropenic. So I'm not convinced that the galactomannan in serum is working as well. And I think the other issue is, you know, critical care patient serum galactomannan sensitivity is around 20%. I would actually probably more combine it with the beta-D-glucan in serum.
From Dr. Kaur, how efficacious is plasma cell-free DNA PCR?
I can answer that in relation to Aspergillus PCR, where we have done a clinical trial, a retrospective evaluation of plasma PCR. What we found is that it had a better sensitivity than serum, and that was put down to the fact that we felt the clot required to form serum was actually trapping some of the DNA, the free DNA that was there. And so it's approaching what we find for whole blood. And so you're in that situation that in our hands, we're getting a sensitivity of around that sort of 85% mark. So it looks like an optimal sample.
I have a question for you. A very frequently asked question is, how do you handle genotypic and phenotypic discordance when we're testing for resistance?
I would basically always err on this sort of the phenotypic side of things. I think the genotypic is good when you've got a patient that's not responding and you know the patient's got levels, and you know it's an indication that there may be resistance. Currently, if you looked at, there was a study by the Manchester group, the Aspergillosis Centre in Manchester, and they used pyrosequencing, and there was very poor concordance between sort of the pyrosequencing indication of resistance and MICs. So currently at this moment in time, I would always go with the MIC through the phenotypic approach.
Well, thank you so much for staying with us all the way from the UK. And